So our next two speakers will be presenting on the updates to the Cytomegalovirus content in the Antibiotic Guidelines. So I'll start by introducing Dr. Tina Marinelli. Tina is an infectious diseases staff specialist at the Royal Prince Alfred Hospital and senior clinical lecturer at the University of Sydney. She is the clinical lead for the Royal Prince Alfred Immunocompromised Host Infectious Diseases Service, the co-chair of the Transplantation Society of Australia and New Zealand Transplant Infectious Diseases Special Interest Group, it's a big one, and a member of the ASID Immunocompromised Host Special Interest Group. Please join me in welcoming Tina to the stage.
Thank you, and thank you for having me. So I guess I wanted to start out as someone who is kind of at the beginning of their career, transitioning into that mid-career where you start to get really, really busy and you have to start to be a little bit careful about what projects you take on. And so when I received an email out of the blue, like, oh, do you want to be part of the Therapeutic Guidelines? I was like, I do not want to be part of another guidelines committee. This sounds like a huge amount of work, sounds like late nights and things, and I guess took a bit of a leap of faith after meeting with Madeline and being assured by the process and speaking to others. And I have to say, I've written a lot of guidelines in my short career, and this is probably one of the most enjoyable experiences I've had, both professionally and personally. It was very, very well organised, and as Crispin and Brendan have discussed, the level of conversation around the table and being surrounded by experts in the field who are not only experts on a research level but practical level, like the pharmacists who are telling us, yes, you can crush this, no, you can't do this, like this is actually how we'll do it and how we deliver these drugs to our patients, was such a rewarding experience. And I think that hopefully is reflected in the guidelines as really, they're not in detail, there's no meta-analyses there's no graphs and tables and things, but hopefully they're a really useful resource for people of all levels. So Dan and I led the CMV topic, and I was conflicted in terms of this topic. I helped with the PBAC submission for maribavir for Takeda, but that was felt to be non-significant, and some unrelated disclosures as well. So the CMV topic was one that changed quite significantly in terms of its structure. I kind of had a look at it, and for me, someone who works in very detailed ways and likes things to be very sensibly put, couldn't handle the way that it was previously structured, and so it changed quite a lot. And why do we do this? And because thinking about the course of CMV in immunocompromised hosts, and it's really a fluid process, and it's not a defined, they're at risk now, they're not at risk now, and they're prophylaxis versus treatment are different things. It's a spectrum of disease. And so if we think about, in this example, using the transplant patient's journey, is that at some stage they're either infected with CMV or they're not, and then they eventually they have their transplant. Once they have their transplant, we either give them prophylaxis or we monitor them depending on which patient group they fall into. They either get CMV or they don't. I mean, this all seems pretty obvious. They either then go on to have secondary prophylaxis, some don't have secondary prophylaxis, and some of them we monitor. And CMV sometimes is no longer a problem for these patients. Other people, they relapse and have lots of problems, and a small percentage of those go on to have resistant and refractory CMV. So it really is a spectrum, and there's a lot of overlap in the way that these different time points are managed in the patient's journey. So whereas Antibiotic 16 had prevention and treatment in completely separate topics that were located in separate places, Antibiotic 17 has put them all together. And we were quite fortunate that our review of this topic fell in line with a very recent review, the 4th International Consensus Guidelines for Management of CMV and Solid Organ Transplants, led by Camille Cotton, which I tell my trainees is the Bible of CMV and solid organ transplant. It has almost everything that you need to know about that. And if you're going to read one paper, that's the one you need. And that came, I think, in 2024, that was published, and just last year, as we were publishing the Therapeutic Guidelines, the equivalent for stem cell transplant and cellular therapy was published. So we were lucky to have those resources and to sort of understand how CMV was how management and prophylaxis was being recommended on an international scale, and then how we brought that into the local context. One thing that's really changed since Antibiotic 16 is the CMV definitions. And nothing more annoys me more than someone on a ward round saying CMV viremia. It's not a viremia. That's not what we're looking at. Or saying they've got CMV disease when they don't. They've got some positive CMV PCR in their blood. So throughout this section, we really brought in the international guidelines and the international consensus of what the nomenclature we should be using is. And it's quite specific: CMV infection, indicating that virus has been isolated, or detection of viral proteins in any clinical specimen. CMV syndrome being the detection of CMV plus 2 or more of symptoms such as fever, malaise, lymphopenia, atypical lymphocytosis, thrombocytopenia, or hepatic transaminitis. And then CMV disease, which has some very specific definitions, really being the end organ disease with an appropriate clinical syndrome matched up with evidence of CMV in the tissue. And that being your things like pneumonitis, retinitis, GI disease. And so we've used that right throughout the chapter and changed that a lot. And then, of course, my bugbear of CMV viremia versus DNA-emia. As ID physicians, we know that a viremia is a culture-based method. You're detecting infectious CMV, whereas what most of us are doing is testing your DNA. So we're seeing a DNA-emia, measuring the CMV DNA by a quantitative PCR. And they're not the same thing, and they shouldn't be referred to as the same thing. And the reason for that, why it's important, the international guidelines actually provide some very good means of how do we interpret the CMV DNA. You know that if we go into our intensive care and we test every single patient in there, that 30% of them will have some sort of detectable CMV in their blood. We know it's not always significant. We know when we start people on treatment, the CMV DNA doesn't always decrease immediately. And so that interpretation of that and understanding how the logarithmic changes occur is really important. We know that a change of less than 0.5 of a log isn't always significant, and that the threshold for change is much, much higher if you're at the extremes of a CMV DNA levels. At the higher levels, you really need more than a 1 log change for it to be significant, so going from 8 to 7, just change my view here, rather than 8 to 7.5 is probably not significant, and the same at the lower levels, whereas when you're in the middle zones, a 0.7 log is likely the threshold for significant change. Now, something that's really exciting in solid organ transplantation and hematology is the addition of new drugs, and not only new drugs, but clinical trials and randomised clinical trials. These are rare as hen's teeth in this subspecialty. So we've heard a lot about letermovir already today, and this is a really exciting drug that's sort of been trying to edge its way in, and we've finally got some evidence, and I think it's really found its home as prophylaxis. So letermovir inhibits, as you can see here with the viral replication, the very last phase of it. So CMV DNA terminase complement inhibitor. So it doesn't actually inhibit CMV replication, so you get replication of the virus to that point that you do actually get DNA produced, but it's then non-replicative. And so this is a problem for many reasons. A, it means it's not actually a very good antiviral. It's terrible for treating CMV disease. You use this to treat CMV disease, it doesn't work, and you'll get resistance very quickly. It's got a low barrier for resistance. And B, when patients are on this, you do get a detectable CMV DNA. It's quite an easy drug to give. It's got both IV and oral formulations. You don't need to adjust to in-renal impairment. It's not recommended in severe hepatic impairment, but of course it's often given. It does have it's a moderate inhibitor of CYP3A4, not as much as azoles, antifungals, but it does have interactions. It's pretty well tolerated. And as previous speakers have mentioned, it doesn't have any antiviral activity against HSV or VZV. So when we're looking at it in prophylaxis, if someone needs prophylaxis against those things, they need to have a second agent. So the evidence for letermovir really came from this landmark study published in New England by Francisco Marti back in 2017, looking at letermovir prophylaxis post-stem cell transplant. And this group, of course, there's particularly a need for it because valganciclovir in the early post-transplant period is not preferred because of the potential effects on the bone marrow. And so this trial was letermovir versus placebo. Both groups had preemptive monitoring, of course, and they gave it for 14 weeks, so 98 days, 100 days being that sort of golden mark. And they looked at clinically significant CMV infection by week 24 after transplantation. And they found in the letermovir group it was 37.5% versus 60.6% in the preemptive therapy or placebo or just preemptive therapy group. which was a significant finding, and the all-cause mortality out to 48 weeks was 20.9 in letermovir versus 25.5 in the placebo group. So this really changed the landscape and provided some very clear evidence that there now is an alternative to preemptive monitoring in the post-stem cell transplant, or post-allogeneic stem cell transplant period. Is more better. So in that study, it was shown that 12% developed a CMV DNA anemia in the 14 weeks after stopping letermovir prophylaxis. And so there was a second study published much later in 2024 where they extended the prophylaxis out to 200 days. And not surprisingly, that resulted in a decreased amount of CMV reactivation. And as you can imagine, it brings your patient so much closer to their T cell reconstitution. So it makes perfect sense. So we've mentioned a few times letermovir is actually not on the PBS for this or for any indication, but there's very, very clear evidence that this patient group benefits from it. And so that's when it came up to the decision that we would actually put this as the number one recommendation for prophylaxis post-allogeneic stem cell transplant, with valganciclovir as number two. When we move over to the solid organ transplant, there's a lot of observational data. There's only one randomised controlled trial, and that was published by Ajit Lamay in 2023. Multiple sites, international multi-centre study, including many Australian sites, looking at letermovir versus valganciclovir as primary prophylaxis in kidney transplant recipients. Why were kidney transplant recipients chosen for this trial? A, there's a lot of them, so it's much, much easier to do an RCT in kidney transplant as opposed to heart transplant. And B, valganciclovir is really difficult to dose in this patient group because their kidney function, particularly in the first couple of months post-transplant, is all over the place. They're at high risk of resistance because you often end up underdosing as their GFR's all over the place and you're not adjusting their valganciclovir. So a drug that's not affected by that, your kidney function is very, it makes a lot of sense to give. So this was a randomised trial looking at letermovir 480 milligrams daily with acyclovir. So technically it's a combination trial, it's a combination drug, and acyclovir does have some activity against CMV. It's not great, but it does. Versus valganciclovir for up to 200 days, looking at the primary outcome of CMV disease to 52 weeks. And it was designed as a non-inferiority trial, and it did demonstrate non-inferiority. And as we can imagine, there was far less neutropenia and drug-related adverse effects in the letermovir group versus valganciclovir group. And so this was taken into consideration when we looked at the solid organ transplant primary prophylaxis recommendations. And we've actually kept valganciclovir as number one. It still is the agent with the most evidence in this group, and certainly outside the kidney transplant, it still does have the most evidence. But we've put letermovir as number two in that group. I think there's a footnote there that the evidence is in kidney transplant, but these actually apply to all solid organ transplants, and it's really being used a lot more, particularly in lung transplant, where lymphopenia is a big problem, and we'll start to see more evidence come through with that. So we've mentioned most of these before, but the pitfalls of using letermovir for CMV prophylaxis, it's not TGA approved or PBS listed for this indication. It does have a really low barrier for resistance, so it's inappropriate for treatment, but it does work well in the prophylaxis space. You do need to monitor. How we monitor that, what the frequencies are when you intervene, is really not being worked out. That's something that's evolving as our clinical use of it expands. It doesn't inhibit the other herpes viruses, so you must use valacyclovir as well or similar. Its role in secondary prophylaxis is not established. There's quite a bit of use of it post the resistant refractory CMV, but not a lot post sort of your non-resistant refractory CMV, and it's very expensive. And so, it's recently gone on the New South Wales formulary for your CMV mismatched allogeneic stem cell transplant, but there's going to be a lot of difference throughout Australia about how it's funded. The second new drug that's made its way into the guidelines is maribavir, which is very exciting because it's the first drug that's PBS listed for CMV, first new drug for many, many years. So maribavir is very similar to ganciclovir or valganciclovir, that it acts much, much earlier in the viral replication cycle and inhibits an enzyme called UL97. So it inhibits the phosphorylation of proteins at multiple stages. And so ganciclovir is also a UL97 substrate, and very importantly, they antagonise each other. Whereas in the old days, we used to combine ganciclovir and letermovir together when you were sort of in your pray that something works type phase, you really can't do that with maribavir and ganciclovir. It's unfortunately only tablets. There's no IV formulation at the moment. No dose adjustment and renal impairment. It also does have some hepatic metabolism and some interactions as well. Interactions there. Now, maribavir does have a very specific side effect of dysgeusia, and it's reported about 30 to 40%, and that's the primary reason for discontinuation in the clinical trials. Most patients that I've had on maribavir do have the dysgeusia, but I've never had a patient stop the drug because of it. And often it's patients that you're looking at, you can be in hospital on foscarnet or you could be an outpatient on maribavir. They're all taking the maribavir. They don't care about that. So I have not personally found that to be a barrier, but it certainly does occur. So maribavir, the second major trial I'll present first, that's the Aurora trial, which looked at maribavir versus valganciclovir for the first asymptomatic infection in stem cell transplant. So this is the first time maribavir was looked at for the non-resistant refractory. This is your primary upfront treating your first episode of CMV. In a phase 3 multi-centre double-blind trial, maribavir 400 milligrams BD versus valganciclovir dose per GFR for up to 8 weeks for stem cell transplant recipients with CMV DNA anemia but without disease. You can see there all the little lines sort of in the middle-ish, some crossing over. The primary endpoint was confirmed CMV clearance by week 8, and so this was designed as a non-inferiority trial, and they pre-specified the difference at 7%. It didn't quite make that. It's like 7.8%. So this is actually not a positive trial, but this is the paper that got maribavir over the PBS. And so it's thought to be numerically significant, and it is. It probably is non-inferior in these specific circumstances. So for this reason, maribavir is recommended as initial antiviral therapy for CMV disease and infection in adults, but it is not first line. There's still the overwhelming amount of evidence is the ganciclovir, valganciclovir. Maribavir is considered second line, and we've put it there with the caveats, the same indications that the PBS indications are, that you can consider it in patients that have a grade 3 neutropenia, a creatinine clearance less than 50, and they didn't tolerate valganciclovir or ganciclovir. And for those of you who work with stem cell transplant, that's actually most of them. So the use of maribavir in that population is increasing quite significantly. There are a lot of caveats. I'll go through the next bit, then I'll talk about the caveats with maribavir. So there's also refractory CMV, some quite clear definitions of that. So refractory CMV is when you've had 2 weeks of therapy, and we all know that when you start CMV, your viral load will not viral load, I just made my own mistake. Your DNA will increase often, and so Camille Cotton, the first author of the International Consensus Guidelines, always says your CMV DNA at week 1 is just for fun. We all do it, but you cannot base your treatment decisions off it. So after 2 weeks of appropriately dosed antiviral therapy, CMV is considered refractory if your DNA has increased by a log, or if you've had a clinical worsening of your signs and symptoms. And then resistant CMV is, of course, a genotypic confirmation. Now, I realised as I was going through my slides on the plane this morning that I forgot to put the slide about the Solstice trial, which is actually the first trial for maribavir and CMV that looked at resistant refractory CMV. And as you can imagine, maribavir did a lot better than your investigator-initiated therapy. Not surprising, because a lot of them were resistant to that therapy, but that's where it had initially gained its traction. And so we've continued to have maribavir as first line equivalent to foscarnet for resistant refractory CMV. Now, some of the caveats with using maribavir is that it's been tested a lot in CMV DNA anemia, but not CMV disease. And so if someone's got rip-roaring CMV pneumonitis, colitis, the efficacy of it really hasn't been tested in those circumstances. It's thought that if you have a very high viral load, maribavir is not going to be the most potent antiviral to bring that down, and so induction with another agent, such as foscarnet, is still recommended. It's limited that there's no IV formulation. There's no penetration into the CNS, so limited if you could, CNS CMV is quite rare, but it doesn't get into your eyes. And like letermovir, it doesn't have activity against your other herpes viruses. So just drawing it to a close, there are some persistent areas of uncertainty that we couldn't make recommendations for or have sort of highlighted within the guidelines. In the prophylaxis setting, when we're using a preemptive strategy, so monitoring CMV and then when they reach a critical threshold initiating treatment, that threshold really hasn't been defined by anyone, and there's lots of reasons for that. There's a lot of variability amongst labs, different types of tests, the patient, lots of factors that have to be considered. And I guess when you look at the end user of the guideline, people who manage CMV in that setting probably aren't going to be referring to therapeutic guidelines as their one source. I think it's there for information, but it's not the only thing that you should be looking at. As we've said about letermovir and then not being listed on the PBS, and we couldn't make any recommendations for maribavir for prophylaxis because there's no data on it. All of the data used a much lower dose and didn't show, it hasn't found its place in prophylaxis, but it probably will at some stage. In treatment, cautiously recommending maribavir as first-line therapy in line with the PBS recommendations and the evidence that we have available, putting it in the optimum approach to resistant refractory CMV. How long do you have to give Foscarnet induction for? What viral load is a high viral load? We don't know. And we haven't made too much mention about the role of CMV-specific T cells, although I think there is a footnote there. And then in terms of secondary prophylaxis, this is an area that there's almost no guidance as to what you should do. Who requires secondary prophylaxis? Who requires monitoring? What do you give? For how long? How do you make these decisions? It's just not known. And so these are areas that will evolve over the coming years. So I'll close off and hand over to Dan.